everyone, and welcome to this webinar on a promising clinical study for potential new treatment for sickle cell and thalassaemia patients with transfusion-dependent iron overload. I'm Andy Richards from Manchester Royal Infirmary. Our presenters today are Dr. Jim Bush and Mike Ravenscroft from Fortrea. In their presentation, they will detail the study and the investigational drug, plus we'll have a live Q&A immediately after their presentation. I'll now hand you over to Dr. Bush and Mike Ravenscroft.
Great. Well, thank you, Andrew. And I just want to return the sentiment. Thank you ever so much for joining us today for this webinar. So as you can see there's a bit of information about myself and Dr. Jim Bush today. But as you're reading that, my name's Mike Ravenscroft, and I'm a clinical operations manager over here at Fortrea in Leeds. Thanks for joining tonight on this webinar for a study that we are currently running at here at Fortrea. Now, as we go through this session, if you do have any questions whatsoever and you would like to ask them to either of us at the end, that's fine. But also, if you don't feel necessarily comfortable asking the questions on here and you would like to do so personally to ourselves later this evening or tomorrow, then our email addresses will be available for contact as well. So at this point, I'm going to hand over to Dr. Jim, who's going to talk you through a bit of a background about the study and the study itself, and also any opportunities for questions. So, Dr. Jim.
Thanks, Mike, and thanks, Andrew, for the introduction. I'm just going to share some more slides, hopefully. Mike, could you let me know if you can see them? Great.
Yes, I can.
Okay, so it's great to see so many people on this meeting. We're really happy to be conducting this study on behalf of Pharmacosmos, the sponsor that are developing this drug. So just as a bit more background about myself, my name's Jim Bush. I'm a medical doctor. I've been working in the pharmaceutical industry for over 20 years as a drug development physician. So we conduct, and I have been conducting this sort of study for a very long time. This study is a little bit unusual in that we are conducting it in a very specific patient population, and that's why you've all joined the call today. So as Mike says, we're here to answer questions about the study and also more generally about clinical research if you have any questions. For those of you who may not feel comfortable asking questions live, as Mike says, we can take questions afterwards. But for those of you who are savvy with this sort of meeting, you could also put questions into the chat and we will try to answer those either at the end or as we go along. So on the slide, on the screen now, you can see the first slide, and that has the title of the study. The title of the study typically for a clinical trial is quite complicated. But what this means is that we are conducting this study to understand more about how the body handles this new drug. And by that, I mean how the drug is absorbed into the bloodstream, how quickly it gets into the bloodstream, how much of it gets into the bloodstream, and then how the drug is broken down and how it is removed from the body. And we do this by using a very small radioactive label that is attached to the drug. And that label allows us to monitor what is happening to the drug and to its breakdown products. And the design of this study is that it will be conducted in both healthy people and then also in patients with iron overload. Now, we've already conducted the study in the healthy volunteers, and now the next part of the study is to conduct it in patients with iron overload. The reason that we're doing this study is because for most drugs, a study of this type has to be done before the drug can be licensed and before it can be put onto the market. So we're not doing this because of any concern with the drug. We're doing this as a standard study that has to be done for most drugs before they can be put onto the market. A little bit more about the drug. The drug is called Petadeferitrin, and it is a new iron chelator. So as many of you probably know, iron chelators bind to iron and help to remove it from the body. So this is, of course, important for people with transfusion-dependent iron overload. So in people who are having lots of blood transfusions, iron can accumulate in the body, and we need to find methods of removing iron from the body. So this drug binds to free iron, and then it is excreted, combined with the iron into the bile, and then the drug and the iron are both lost into the feces. So this is a way to remove iron from the body. As with all drugs, this drug was initially tested in animals, and it was shown to be very efficient at removing iron. So in animal studies, dosing for just 10 days resulted in a statistically significant reduction in iron content in multiple tissues, including the heart, the liver, the kidneys, and the pancreas. And data from human studies has also shown that this effective iron clearance could be achieved with dosing that's not every day necessarily. So dosing may only need to be 3 times per week or every other day, which is different to some of the other iron chelators that are already on the market. In terms of the trial design, so if you were to take part in this study, there are several parts of the study. So the first part is the screening visit. So for the screening visit, you would come to our clinic and you would be here for about 2 hours normally. And in the screening visit, we will talk to you about your medical history. We'll make a record of any drugs that you may be taking. We'll go through a physical examination and we'll do some tests. So we'll do an ECG and we'll do some blood tests. And this is just to make sure that you meet the criteria that are required to enter you into the study. If you pass the screening visit, you would then be invited to come to one of the in-clinic periods, and we'll go through some of the dates of when those are planned later on. The in-clinic period, you would come into the clinic the day before the dosing, and then on the day of the dosing, you would receive a single dose of Petadeferitrin. And the dose level has been set at 1700 milligrams, and I'll give you some more information on the next couple of slides about how safe that dose level is. You only receive the drug on that one day, so it's just a single dose of the study drug. The drug is given as capsules, so in order to make up that 1700 milligrams, we have to give you a total of 6 capsules, and you swallow these capsules as normal capsules with a drink of water. Out of those 6 capsules, 2 of them contain a very small amount of radioactivity, and it's that radioactivity that we then trace to look at what happens to the drug. So after the dose of the drug, you have to stay in our clinic while we do tests. So daily you'll have some tests to look at, some blood tests, and we also collect your urine and feces. So every time you go to the toilet, we have to collect it so that we can analyze the urine and feces to see how quickly the drug comes out of your system. The discharge is flexible, so every day we're monitoring how much of the drug has been removed from your body. And when you get to a specific cutoff level, so when we've recovered more than 90% of the drug from your body, then you can go home. So that could happen anywhere between day 5 and day 11. Day 11 is the longest, but it could be as early as day 5 that you're allowed to go home. And when we did the healthy volunteer part of the study, we found that most people went home on day 6. So I can't guarantee that it will be the same in patients, but that is the information that we have so far. Most people went home on day 6. After the residential period in the clinic, you would then be followed up later on by a phone call, which is about 2 weeks after the dose. And after that, that's the end of the study. There are no more visits to the clinic. So that's an overview of the trial design. Just to give you a bit more background about the previous studies that have been done with this drug. There have been 3 clinical trials that have been completed with the drug in the past in both healthy volunteers and also patients with beta thalassaemia. And this table gives a kind of brief overview of those studies that were completed. In healthy volunteers, single doses have been given, and the highest dose that was given was 7,200 milligrams as a single dose. And then in patients, doses of 1,200 milligrams and 1,600 milligrams have been given, but those doses were given up to twice a day for 28 days, 14 to 28 days, depending on which part of the study they were in. So in all of those studies previously, the drug was very well tolerated. There were some minor side effects, so things like mild headaches were reported. In the patient part of the study, after 2 weeks, there were some mild changes in kidney function, but these were all shown to be reversible, and that's known to be a side effect that happens with other iron chelators as well. So I'm just giving you this information to put the dose level of this study into context. So if you remember, in this study, you would only get a single dose, and that dose level is 1700 milligrams. So risks, with every clinical trial, we have to talk about risks to participants. With the dose level that we're given, we expect this to be safe and generally well tolerated. There is a risk that there might be some mild adverse effects, and the most likely things that we expect to see are things like headaches, nausea, and other gastrointestinal symptoms. Again, when we did the healthy volunteer part of the study, we had one volunteer that reported abdominal bloating and some loose stools and nausea. And we also had a volunteer that reported an episode of headache, but there was nothing more significant than that in the healthy volunteer part of the study. We also have to consider risks associated with the radioactivity, because we're giving a dose of radioactivity in this study, but that dose level is very low. And we frequently in this type of study give dose levels of radioactivity that are higher. So in this study, the radioactive dose will be 0.1 millisieverts. I don't expect you to know what a millisievert is. It's a unit of measuring radioactivity. But to give you some context, in the UK, everyone is exposed to radioactivity just as part of normal life. Radioactivity is coming from space, and radioactivity is released from rock. And so we're all exposed to radioactivity generally, and the average background radiation in the UK is about 2.7 millisieverts. So if you put the dose level of 0.1 millisieverts into context, this is a low level, and it's a dose level of radioactivity that you would normally be exposed to over a normal 2-week period. There are some other figures on there to show you what happens if you have a CT scan. So if you have a CT scan, you have much higher doses of radioactivity, and these are also generally considered to be safe. Ethics committees nowadays like us to put the dose of radioactivity into context by telling you what the risk of developing cancer might be as a result of that dose. And the risk of cancer is extremely low. So from taking part in this study, the risk of developing cancer would be expected to be about 1 in 10,000, so extremely low. Benefits. So because this is a single dose study, you wouldn't be expected to gain any clinical benefits yourself, but you would be benefiting other patients with transfusion-dependent iron overload. As I said earlier on, we have to conduct this type of study in order to get a drug onto the market. So the research needs to be done in order to allow the drug development process to proceed. So you may be helping patients in the future, and of course you would be compensated for your time and for your time for taking part in the study and for the inconvenience. And we'll show you the inconvenience payment later on as well. So this is just to show you where the study would be conducted. This is some pictures of the outside of our building. We recently moved into a brand new phase 1 facility. So this is a clinical research unit that has about 100 beds, and we moved into this facility just over 2 years ago. Some pictures of the inside. So the inside, this is the screening department. It's just like a normal hospital clinic, but but a bit newer. So this is where you would come for your screening visit and have your initial assessments done. And then when you come into the clinic, these are some pictures from inside the clinic. So we have hospital beds that are made up into a ward kind of environment. Generally, when we conduct patient studies, we put patients into a bedroom on their own. And if you have a carer that comes in with you, you would normally share a bedroom with your carer, but not with any other patients or any of the healthy volunteers that may be in the clinic at the time. So some more pictures. The picture on the bottom right, this is the roof of our facility. So you can see that we have a lovely garden on the roof of our facility. So while you're here, you won't be confined inside all the time. You'll have the opportunity to go outside. This is the flyer that we have for the study, and on the right you can see the planned dates for the study. So the admission dates that we're planning are all in November, so the 6th and the 11th of November, and that would mean that the dosing dates would be the 7th and the 12th of November. Over on the left, you can see the flyer, which just gives more information. So it gives information about the stipend for the study. In addition to this stipend, which is for your inconvenience, you'll also have your travel payments to and from the clinic reimbursed as well. And it's also important to point out that the 11-night stay is the maximum that it could be. You may be allowed to go home before that. If you go home before that 11 nights, you would still be eligible for the full stipend. So the stipend is not reduced if you go home earlier. So I feel like I've talked a lot there, Mike, and hopefully I've given you lots of useful information. On the slide here, you can see the email address of myself and Mike. Dr. Quentin Hill, some of you may know, he is the consultant hematologist that we're working with on this study. So we work with him on several clinical trials, and we have a very close relationship with Dr. Hill. And then some of you may also know Charlene from Manchester University. So if you have further questions that you want to send to us after the webinar, then you can use those email addresses. But as Mike said at the start, we'd be happy to take any questions that you may have now as well.
Sure, thank you very much, Dr. Bush. Fantastic. So yes, at this point, we'll hand out to the audiences. Does anybody have any particular questions that they would like to ask us at this particular point?
Question 1. For participants with beta thalassemia major, will existing medications need to be paused or stopped for the duration of the trial?
So if you're taking an iron chelator, that have to be paused. So the requirements of the study are that the iron chelator would have to be paused 7 days before the start of the study and for the duration of the residential period, and then it could be restarted again. So that's the main exclusion. There are, in the protocol, there are allowances for people to take other medications, and so there's a list, and there's a list of drugs that are allowed because these have been thought about by the sponsor. They understand that patients are going to be taking other drugs and may have other conditions associated with beta thalassemia. Yeah.
Question 2. Is there a required or recommended time frame for participants to receive their regular blood transfusion relative to the start of the trial?
Another great question. So the rules for transfusion is that the last transfusion must be more than 3 days before the dose of the study drug, and also they shouldn't expect to be needing a transfusion during that residential period, so that kind of 2-week period.
Question 3. What are the age restrictions for trial participants?
So you have to be more than 18 to take part in the trial.
Question 4. Is a patient still eligible for the trial if their ferritin levels are high, or if they are over the age of 50?
Over the age of 50 is fine. I'm just looking at the protocol because there are criteria for ferritin levels. And so there are several criteria that have to be met to show that the patients are iron overloaded. And what we would normally do is contact your consultant in order to get information about scans that you've had of the liver, etc., recently to ensure that you meet those criteria. The criteria were all advised by Dr. Hill. So having a high ferritin level is actually one of the criteria that is needed.
Now, I can see that we've got a couple of hands out there as well. I'm just going to very quickly go to a message that we've got in the chat. Are you able to participate in the study if you have thalassemia minor, Dr. Jim?
Oh, that's a good question. I'm just going to look in the protocol.
Lots of good questions today. Thank you.
Yep.
Keeping Dr. Jim very busy.
Go on to the next question, Mike, and I'll come back to that.
Of course I will.
Question 6. If the drug is approved and marketed, will its use be restricted to those over 18, or will it be available for pediatric patients as well?
So, yeah, that's an interesting question. I think that will be up to the sponsor and how they apply for their license. So what sponsors often do is apply for a license for adults initially, but they do have to submit a development plan for children. So they often extend their license for children later on. The way that drugs are developed for children are slightly different for different age groups. So you have to do, older children are almost treated as adults, and then there are different things that have to be done for the different age brackets. So I would think it would start off being licensed for adults, but then maybe extended to children.
Question 7. What is the typical time frame for the entire process, from the trial phase to the drug being finalized, marketed, and available to the public?
Another good question. It can be a very long process. So it can be anywhere, it can be around 10 years for the whole development process. This company are already in what we call phase 2. So they're already partway through conducting trials in patients. But I can't give you an idea of how soon it might be licensed.
Question 8. As a recipient of frequent blood transfusions and having high iron overload, how close to the trial start can I continue my current combination chelation routine?
For current iron chelators, you would have to stop 7 days before the dose of the drug, and for the duration of while you're in the clinic. And then for your transfusions, you'd have to arrange those so that your last transfusion was more than 3 days before you came into the clinic. If you're normally on a 3-week interval, then that should be, even if you were in the clinic for the full 11 days, total of 14 days, and that should be fine.
Question 9. Does a prior medical history of a kidney transplant due to sickle-related complications interfere with or affect eligibility for the trial?
Another good question, which I wasn't expecting. So I think as long as your kidney function is okay, then that should be acceptable. But I think you may be taking other drugs associated with your kidney transplant. So we would have to assess those drugs to see if anything was going to interact with the trial. And I might have to discuss those with the sponsor, with their medical team as well.
Question 10. How feasible is it for participants to work remotely and maintain their current work commitments during the trial, especially given the residential period?
Very feasible, yeah. Sorry, Dr. Jim. Yeah, very feasible. We have a dedicated quiet room, workroom here at the clinic here in Leeds that has neutral backgrounds, that has soundproofing as well. So if you did want to participate and come and work, we have patients and volunteers that do actually work from the unit themselves whilst on study as well. So to answer your question, it's absolutely fine. Okay, I'm just going to go back into the chat group now. At this point, we've got a couple of more questions as well. I hope people are okay for time just whilst we field these last three. And again, if you were unable to answer a question, then please don't hesitate in emailing us afterwards. What about if you have a ferritin level of around 3,000 to 4,000, but your T2 score is around 3 to 4? I'm now going to revert to Dr. Jim again for that question there.
So ferritin levels are allowed between 1,500 and 4,000. And T2 scores between 4 and 30 are acceptable.
Okay, so hopefully that answers your question. Sorry, Dr. Jim.
Yeah, that's based on the way the protocol's written is slightly flexible because it's based on assessments over a 2-year period. So I would ask your consultant or Dr. Hill's advice on whether or not your SENS over a period of time met that criterion. But the way the protocol is written is with flexibility in mind, so that we want to ensure that people are overloaded, but we don't want to be too restrictive.
Are you able to take part if I have pyruvate kinase deficiency? Sorry about the pronunciation there, everyone.
No, you pronounced it well, Mike. Pyruvate kinase deficiency. That's something, again, I think I would have to discuss with the sponsor, but there's nothing specific in the protocol that says you couldn't take part.
Since one of the possible side effects is headaches, is it safe for patients with diagnosed migraines to still take part in the study, Dr. Jim?
So for some studies, we do specifically exclude people with headaches. So when we know that the drug is going to cross into the brain, we do often specifically exclude people with a history of migraine. We don't think that's going to happen with this study. We think it's the headaches that we have seen are mild and they're not migraine type headaches. So I don't think there's any specific exclusion there. Of course, we would assess how frequently you have migraines, and if you're having them, very, very frequently and needing treatment, then we may exclude you. But if it's something that happens more infrequently, then we could consider including you on a case-by-case basis. But there's no specific exclusion for migraine.
Question 14. My son has thalassaemia and is a university student. Will the trial require full-time residential stay in Leeds? And how does this affect academic commitments?
I suppose it depends what sort of course he's on and whether or not he could attend remotely or work remotely. As Mike said, we have great abilities for people to do that. The study it is residential.
Question 15. Is there a specific cut-off date for trial applications?
The screening period for this trial is quite extensive. I think it is 56 days before the check-in date.
Yeah, and I think the other thing as well is that we have many students here on trial as well that are able to facilitate their courses remotely as well. But we will do what we can. But we do have a dedicated recreation room as well with numerous games consoles and fitted out with one of the largest TVs that I've ever seen. So he doesn't have to bring his PlayStation or anything. We have everything here.
Sorry, Mike, just in follow-up. I've just been looking at the protocol. The minimum age is actually 20 for the patient part. It was 18 for the healthy volunteers, but your son would be eligible if he is 20 at the time of the study.
Question 16. How do you know if you need this trial?
you don't, as a patient, you don't need to have this done. The company developing the drug need to do the study in order to continue with the development of the drug. So in order for them to get the drug licensed, the drug regulators in various different countries, the UK, Europe, America, expect them to have done this type of study so that they can show how the drug is broken down and removed from the body of in patients. So you as a patient don't need to have this done, but you would be helping the company to develop the drug, and you'd be helping patients in the future by participating so that hopefully they can get this drug onto the market later.
Well, look, I mean, first of all, thank you ever so much for attending this evening. It's been absolutely fantastic to talk with all of you, and hopefully we've answered some of the questions and any concerns that you may have had around this. But please don't hesitate in reaching out. We've got contact addresses there, email addresses, and please reach out for anything in particular. And again, like Richard said, for anyone that missed the start or any section of the presentation, we are going to be circulating the recording as well, and some elements around there. We're going to aid confidentiality, so we'll edit out some patient details as well. But please reach out, please contact us. We're happy to take conversations forward as well. So if you do have any questions or concerns, then don't hesitate in reaching out. But first of all and last of all, thank you ever so much for your time this evening. Dr. Jim, did you want to add anything?
Yep, just to add my thanks. Thank you all for joining in the evening. Thanks for your interest and for staying on the call for so long and for all of your questions. It's been great to talk to you, and hopefully we'll meet some of you soon.